over the 20 years that you've been, that there's been so much change in the way what we've seen, the progress in treating patients. If we were looking forward, we're at the end of the year already, and there's a lot coming next year, in the next year or two. What really excites you about what's coming down the pipeline? And that could be therapies, it could be in programming, it could be in testing. If we open it up, what's the most exciting for you?
Thanks so much. So I would say that crossing that bridge between the science and the trials and implementing things in the clinic to really optimize how patients do and feel is what is most exciting to me. I've been doing a lot more work with liquid biopsy testing, and this is very interesting. We have the ability to diagnose patients' cancer types, to direct therapy, to diagnose resistance, and also figure out, maybe how much or how little treatment a person needs. If you have curative treatment, are you really cured or not? Do you need more? Did we give you too much? Can we scale back? And the same in the advanced disease setting. How much is enough? Do you need more drugs? Do you need fewer drugs? Have we got the wrong drugs? And so I'm very excited about that. Over the next 1 to 2 years, we're doing a lot of work developing trials. But again, they're very practical trials. They're really aimed at everyday patients and improving everyday patient outcomes. What we spent the last few years doing is really improving molecular testing on the ground. So not just theoretical, but really showing what the value is in the clinic of precision medicine, and what it means to avoid chemotherapy, and how valuable it is, both with tissue biopsies, liquid biopsies, genomics, targeted treatments, immunotherapy. So we've been doing a lot of work like that, and it's really been great to see it come to fruition, be able to offer that to patients now every day. And for me, my next short-term frontier is introducing liquid biopsy to the clinic. And then after that, we're learning that cancer, in medical school, we learned that cancer was clonal. And what I mean by that is that, there was one cell, then there were daughter cells, and they were all exactly the same, genetically, epigenetically, phenotypically, they were identical. But we've learned that is so far from the truth, and that neighboring cells can be completely different. And things that we thought, for example, somebody with an EGFR mutation, which is an important kind of lung cancer, couldn't possibly have anything else going on. And yet we've learned there are different kinds of EGFR mutations within the same tumor. You can see different kinds of mutations without EGFR in different cells, even in the same biopsy sample. And so I think for the next 10 years, that precision, that ability to look at single cells within the tumor, that'll be the next thing that we have to say, okay, the science and the trials are great. How do we bring this to patients? How do we make it practical? How do we make it real world? How do we make sure that at the level of every patient, not just the select few in trials, we can really do this thorough diagnosis of cancer, resistance, treatment planning, and also optimize the timing, right? Maybe you don't need everything at the same time. Maybe you need some things on day 1, some different things on day 2 or day 3. So that's those are my short and long-term things that I'm really excited about.